Picture this. It's 2 in the morning, a patient rolls in with a swollen, distorted airway, there might be some angioedema, some blood at the back of the throat, anatomy that you can barely recognize. You get your blade in, lift, and you get the worst view in the business, a Cormac-Lehane grade 3 or 4. No cords, just a sliver of the arytenoid and a whole lot of nothing. And in that moment, the thing I reach for is a long, skinny, slightly bent piece of plastic, the bougie. I feel for the tracheal rings, I railroad the tube over the top, and we're in. Crisis averted. Here's the thing that bugged me for years though. When I trained, the bougie was the backup, the break glass in case of emergency tool. Plan B, and I started to wonder, if it's that good when things go sideways, why am I not reaching for it the first attempt every time? G'day team and welcome back to Overheard in the Emergency Room. I'm Dr. Coyce, emergency physician, evidence nerd, and your guide through the messy, fascinating world of medicine. This is Overheard Journal Club, the short, punchy format where I break a single paper down the way I would for a resident over coffee in the workroom and tell you exactly what to do with it on your next shift. I go through PICO, results, what's good and what's not, and the bottom line. Last time on Journal Club, we argued about video versus direct laryngoscopy. Today, we go one layer deeper into the airway toolkit and settle a question I've been chewing on for a long time now. Should the bougie be your first move or your backup? The paper that we'll discuss today is a 2024 systematic review and meta-analysis from the Annals of Emergency Medicine. Von Hellmann and colleagues that pooled every decent study on bougie use and first attempt intubation success. Quick housekeeping before we get into it, hit the like, subscribe and notification bell. Go over to drcoyce.com for the companion blog, full reference list and a link to the paper. Right, let's go. To understand why we needed this meta-analysis, you need the backstory, and it's a genuinely good one because it's a story about a result that didn't replicate. In 2018, the BEAM trial came out of Hennepin County in Minneapolis. It was single center, emergency department, and the result was jaw-dropping. First attempt success of 98% with a bougie versus 87% with a standard styleted tube. An 11% absolute difference. For an airway intervention, that is enormous. The bougie evangelists, myself included, lost their minds. And then in 2021, the same group ran the sequel, the Bougie trial. It was a bigger, multi-centered trial in critically ill adults, and it found nothing. No significant difference in first pass attempt success between bougie and stylet. So now we've got a problem. One beautiful single center trial says the bougie is a game changer. One big multi-center trial says it makes no difference. And the 2022 American Society of Anesthesiologists difficult airway guidelines sit on the fence. They endorse adjuncts like the bougie for anticipated difficult airways, but stop short of recommending it for everyone every time. That is exactly the situation a meta-analysis is built for. Your individual trials may disagree, you pool them, and you get a single best estimate, and you see whether the signal survives. And that's the question on the table today. Across all the available evidence, does using a bougie on the first attempt actually get the tube in? So the paper in PICO style, let's walk through it. Population, intervention, comparator, and outcome. The population were adults being intubated in any setting, out of hospital, emergency department, ICU, and the operating room. They excluded mannequin and cadaver studies and studies that simply compared one type of bougie against another. And this is important, studies using only hyperangulated video laryngoscopy or channeled devices. We'll come back to why that matters. They took randomized control trials and comparative observational studies. The intervention. Intubation using a bougie, typically a standard geometry blade with a coude tip introducer. The blade detail is not trivia. You need a standard geometry view to railroad a bougie effectively. The comparator. Intubation with a standard stylet or no introducer at all. The outcome. The primary outcome was first attempt intubation success. That is, tube in the trachea on the first laryngoscope insertion. Secondary outcomes included first attempt success without complications like hypoxemia, post-intubation arrest, intubation duration, airway injuries, and esophageal intubations. On the methods, and this is the part that earns the paper my respect. A medical librarian searched 5 databases from inception to June 2023. They screened 3,915 records, removed 1,200 duplicates, reviewed 134 full-text articles, and landed on 18 studies. That was 12 randomized controlled trials and 6 observational studies, totaling 9,151 patients. It was pre-registered on Prospero, dual independent reviewers were used, Random effects models were incorporated and grade was assessed to rate the certainty of evidence. This is textbook systematic review hygiene. Okay, so the headline number first. Pooling all 18 studies, Bougie use was associated with a higher first attempt success. The relative risk was 1.14 with a 95% confidence interval of 1.06 to 1.17, so an 11% relative improvement in getting the tube in on the first pass. The confidence interval doesn't cross 1, so it's statistically significant. But hold that thought, because the heterogeneity was high. An I-squared of 83% and grade rated the overall certainty of evidence as low. Now the subgroups, which is where it gets clinically useful. In emergency department studies specifically, 9 studies of just over 8,000 patients. The effect held. The relative risk was 1.11, with a confidence interval of 1.05 to 1.16. So this isn't an operating room artifact. It shows up in our world too. And here's the one that changed my thinking. In patients with a genuinely difficult view, Cormack-Lehane grade 3 or 4, the relative risk jumped to 1.6, with a confidence interval of 1.4 to 1.8. That's a big effect, but here's the catch. Only 5 of the 18 studies, about 585 patients, reported that subgroup. So it's a strong signal on a thin slice of data. There was also secondary analysis where the authors removed the largest single data set, the Bougie trial, the one that showed no difference, and the pooled benefit got stronger. Now, that cuts both ways, and we'll talk about it in the appraisal later on. On the safety and secondary outcomes, keep these in your head. Hypoxemia, there's no significant difference with a relative risk of 0.93, but a wide confidence interval of 0.66 to 1.31. It was underpowered, basically. Airway injuries, a signal in the wrong direction. Relative risk of 1.55. There was more oral and airway trauma with the Bougie, though in the ED-specific studies, there were no direct airway injuries reported. Intubation duration. It was slightly longer with the Bougie, up to about 13 seconds on average in the ED studies. It's real, but it's small. Esophageal intubation. No significant difference. Relative risk of 0.59. So the story so far, a modest overall benefit, a much bigger benefit in difficult airways, a slightly longer procedure, and a small bump in minor airway trauma. Now, let's pressure test it. So what's good and what's not? And this is the part of Journal Club where you stop being a fanboy and you start being a critic. I love the Bougie, and loving a tool doesn't mean ignoring the weaknesses in the paper that defends it. So what's good? The search was comprehensive. 5 databases, an expert librarian, Prospero registration, 2 reviewers, and grade assessment of quality of data. This is how you do it. 12 of the 18 studies were randomized control trials, and the pooled sample is over 9,000 patients. Now, what's not so good? That 83% heterogeneity is the elephant in the room. They pooled out-of-hospital, ED, ICU, and operating room intubations into one number. But a calm, fasted, optimized OR patient and a crashing trauma patient with blood in the airway are not the same intubation. Lumping them produces a single estimate that may not describe any real patient in the emergency department cleanly. The certainty is genuinely low. 6 observational studies drag in confounding, and a funnel plot asymmetry hints at publication bias. The primary outcome, first attempt success, is a process measure, not a patient-centered one. And the big one, the operator skill problem. Beam hit 98% at Hellmann, a center that lives and breathes the Bougie. The multi-center Bougie trial with mixed experience found nothing. That's the same pattern we saw in the device trial, where the gap between devices shrank as operators got better. So the honest read on the Bougie excluded analysis isn't the Bougie is even better than we thought. It's the effect depends heavily on who's holding it. So what is the net here? Well, modest benefit overall. There's convincing benefit in difficult airways. There's low certainty and a heavy dependence on skill. The criticisms are real, but the intervention is cheap, low risk, and trainable. For me, that combination still moves the needle. So how should this modify your practice? 4 things. 1, promote the Bougie from plan A to plan B, and do it deliberately. Where I trained, the airway plan was Bougie as a backup. This paper is good enough that I'm flipping that. My new default with a standard geometry blade is Bougie-First. Not because the average effect is huge, it isn't, but because you can't reliably predict which airway will be the grade 3 until you're already in it. And that's exactly where the Bougie shines. 2, Match the tool to the blade. The Bougie wants a standard geometry view, direct laryngoscopy or standard geometry video blade. If your shop defaults to hyperangulated video laryngoscopy, you still want to stay fluent in standard geometry DL plus Bougie, because the day the camera fogs and the lens is coated in blood or the screen dies, that's your bailout. And it shouldn't be the first time you've used it that month. 3, respect the skill curve. You get good at what you practice. The whole beam versus Bougie story is a parable about reps. So train it deliberately. Simulation, the Kiwi grip, repetition on routine airways so the movement is automatic when the anatomy is ugly. And here's a genuine pearl. If you've got a Hellmann graduate in your group, ask them to come intubate with you. Their program has some of the best Bougie teaching and research anywhere in the country. 4, don't ignore the small downsides. There was a signal towards minor trauma airway and a few extra seconds per attempt. Neither is it a deal breaker, but it just means the Bougie on everything reflexively isn't quite the answer. Once you have a clean grade 1 view, a stylated tube is perfectly reasonable. The point isn't dogma, it's having the Bougie loaded in your hand and in your muscle memory before you need it. Full disclosure on where I'm personally landing. I'm moving Bougie to my first line, and I'm booking myself some sim time to make the change real rather than aspirational. Practicing the change is the change. So here are your 3 takeaways from today's episode. 1. Across 18 studies and over 9,000 patients, Bougie was associated with a modest improvement in first attempt success. The relative risk was 1.11, but the certainty is low and the heterogeneity is high. There is a modest, real effect, which is imperfect. 2. The benefit is much larger in the difficult airway, that's grade 3 or 4 views, where the relative risk hit 1.6. That's the strongest argument for keeping it close on every attempt. 3. With a standard geometry blade, consider moving the Bougie from backup to first line, and then practice it, because the evidence says the tool is only as good as the hands that are using it. If you got value from this, please like, subscribe, and hit the notification bell. Drop a comment with the next paper you'd like me to break down on Overheard Journal Club. Listener requests always jump the queue. Head over to drkois.com for the full companion blog, reference list, and a link to the paper itself. I'm Dr. Kois. Let's keep chasing less bad days and more good decades together. I'll see you next time, and hopefully not in my emergency department.